ICLs now, phakic IOLs basically. It's going to be a very short talk because of the time that has gone by. In ICLs, basically, now these are some of the important points for beginners as well as for those who may face some of the problems that I have faced along the way initially when I was doing it, sometime around 2010. Of course, like any other refractive surgery, you have to get the basics absolutely correct. And always stick to the limits of the white to white and the anterior chamber depth as is prescribed for all phakic IOLs by the manufacturer. So namely, not less than 2.8 and always above 11.5. Minimize air drafts when you're loading and always load the ICL and keep before you start on the patient. The ICL is a very delicate object, especially the central optic, which is very thin. So it would be a good idea only to use prescribed instruments and touch the haptics. So this is a short video of how to load the ICL correctly. You can see that instead of the ICL being pulled into the cartridge, the cartridge is passed over the ICL and it's locked in place, and then the soft tip applicator is pushed forward, which makes sure that the ICL does not suffer any damage. And as you are inserting it into the eye, the tip has to go inside the incision and the ICL has to be injected very slowly, in such a manner that even if it's flipping to one side during the injection, you can always turn your cartridge and bring it to the right position. The haptics need to be tucked in gently into the sulcus, and that can be easily done with a Phakic manipulator. Now, sometimes you may have an untucked haptic in the anterior chamber, and that's easy to detect if the pupil is slightly small because of the manipulations that have happened, and you can tuck it back. But in case you have a haptic that is outside in a very large pupil, it may not be hard to detect, especially because it's a very thin transparent haptic. And so you have to be very careful that you have tucked all the haptics in before you come out. Otherwise, you will need to take up the patient again the next day and would have already damaged a few endothelial cells by then. Similarly, when you're washing out the viscoelastic, the flow of current may lead to iris coming out of either the side port or the main port. So it's very important that you dilate the pupil first, even though it might have constricted during the procedure. So using a pharmacological agent before wash will be a good idea to both wash under the ICL as well as over the ICL. And while we do that, we have to make sure that the flow of the draft that comes out, the fluid that comes out, is along the top of the iris and it comes out rather than under the iris and pushing it out of the side port. Then this is something I've faced in around 2 patients so far. That could be because of overinflation of the chamber where the pupil becomes static. The intraocular pressure rises, but the patient doesn't present immediately, usually in about 3 or 4 days. It resolves very slowly after good IOP control. But the pupil comes back only in a couple of months. Now, in case there is a rotation of the ICL from away from the axis, so a re-rotation of the ICL, this might sometimes rarely be required in keratoconus patients where the cylinder may fluctuate, or if a patient has had a trauma like in this case. Then the rotation of the ICL involves plucking it out of the sulcus from that point and repositioning it back rather than just dialing like you would do an intraocular lens. So you can see how the manipulator picks it up from the sulcus and repositions it to the next position. And the same thing for the opposite pole as well. If the vault is very high and it produces peripheral anterior sinus and angle closure, then that's an indication for removal of the ICL. Or if it has come so close to the lens and has caused cataract, that's another indication. So where explantation of the ICL is also a smooth procedure. You just need to take the haptics out of the sulcus into the anterior chamber, and the ICL is so pliable that you can pull it out through that 3.2 incision you had made initially. Now, when you do cataract surgery in a patient, now this is a patient who is post-traumatic with an ICL. He developed an anterior capsular cataract. You may either remove the ICL out of the chamber, do the cataract surgery, and put in an intraocular lens. But this patient wanted a multifocal, so we did the procedure under the ICL, which can be done provided you have provided very good cushioning between the cataract and the lens doing all the procedures. Please remember that the ICL has been brought into the anterior chamber. There's a lot of viscoelastic between the ICL and the cornea as well. Being a soft cataract can be easily taken out with the coaxial. And this was followed by a multifocal intraocular lens implanted into the bag along with the placement of the ICL back into the sulcus. So you'll note that all the procedure is done through one edge of the ICL after turning it in the direction of the main incision. Viscoelastics need to be washed out very well so that there's no formation of interlenticular membranes. Now, this is another patient who unfortunately had a retinal detachment again following trauma, following an ICL. He got stuck by his own belt, it seems, and so this was the retinal detachment procedure being done under the intraocular lens. So that is also possible. Following that, the intraocular pressures need to be monitored very well. Thank you very much.